Good preparation for a pericardiocentesis procedure will make a big difference to how smoothly the whole thing goes. Preparation for the procedure is absolutely key, and part of that is explaining the situation to the patient and giving them confidence that you're going to do the procedure well and they're going to be kept comfortable during the procedure, because if they're calm and let you get on with it, it will make your life much easier. Look at things like having a wedge in so that the patient is in a more comfortable position, and that can help to pool the fluid. It might be that a pillow on one side leaning slightly over to the left will improve the way the fluid pools. It's a dynamic situation. Sedation is an important consideration. It's very important to have the patient comfortable, letting you calmly get on with things. And it's obviously very important not to give somebody an unpleasant experience if you can at all avoid it. But there is a risk of vasodilation if you sedate the patient and they have less adrenaline keeping their blood pressure up. And if somebody has tamponade physiology, there is a danger that their blood pressure will drop potentially seriously when you sedate the patient. So I would have a note of caution, and if you can manage without sedation, I would prefer to manage without sedation. If you need it, something like midazolam or diazimals can be very helpful. It helps enormously to know what you're going to do before you're actually in the procedure doing it. If you plan to do an echocardiogram at the start of the procedure, well, that's fine, I'd recommend it, but you'll have the consultant, you'll have all the staff from the lab watching you do the echocardiogram, and your time to relax and think without that pressure is gone at that point. So I would strongly recommend that you scan the patient before they reach the lab, and that you have a planned approach before they get to the lab, and then do the echo before starting the procedure, but do it with intention that you're confirming what you already know rather than trying to plan your approach at that point. I always look at an echocardiogram before I agree to do a pericardiocentesis, because it might not even be practical to do the procedure. The windows might not mean that the risk benefit is in favor of going ahead. So what do we look for with the echocardiogram? Well, it's a very active process. Don't just scan. Be thinking about these considerations when you do your echocardiogram. You're looking for the biggest gap between the pericardium and the myocardium. And you also want to know how far it is from the surface, from the skin to the pericardium. And the best angle of approach in order to get these distances. It's no good knowing the separation and the distance if you don't know exactly the angle that you have to approach to have those distances. Any slight change in angle could potentially have a big impact on those distances. You want to know the best patient position, and that might be with a wedge, or as I said, using a pillow to adjust the angle of make the patient lean slightly over to the side. And you need to know the anatomy of other structures you're at risk of damaging. So is the liver in the way? If you're thinking about going parasternally, is the internal mammary artery at risk? And the other big thing that you're considering is your margin for error. So it's all well and good to have a good approach subcostally, but if that requires that you go in a very precise way to avoid the liver, then that might not be the best approach. If, for example, apically, you have a much wider margin for error, even if the absolute depth of the fluid isn't quite as great. When we think about echo separation, remember that the separation in systole can be very different to that in diastole, and it's never a static image. The heart is moving around, so there is a danger that even if it looks just about adequate in diastole, it's not good enough. Often it will be absolutely fine if you have a big pericardial effusion, but bear it in mind, and bear in mind that when the separation is different in a small area, it could be very hard to hit that angle when that depth is maybe 8 centimeters. And look, we've got the liver in the way there. So this sort of subcostal appearance really would be extremely challenging, and I wouldn't attempt this from this angle unless it was tamponade and we had no choice. There are lots of other angles of approach. We don't have to go subcostally, and actually I probably most frequently go apically. When we're doing this, we're looking at effusion which is often quite close to the apex, but there is usually quite a bit of space around the lateral wall. And I find it's very helpful to think in terms of the echo probe as my needle. So I could take that picture and think I need to go at this angle to the echo probe, but I find it's much better to rotate the probe so that it is my needle and I don't have to do an adjustment for the angle of the needle. I simply need to put in the needle at the exact angle that my echo probe was at. And I said to think about the angle and depth and the error margin. Can you see here that we've got relatively little angle of error margin, but we have a great deal of depth error margin, particularly if we are in the middle portion of this angle of approach. So this option is perfectly doable, but we will have to be very precise, and this is why it's so critical to think of my echo probe as my needle, so that I simply have to replicate that. And I would always sheath the echo probe with the sterile sheath so that I can do a picture as the very last thing that I do before I pick up the needle and insert it. If we're going parasternally, we're going straight down, and you can see that there isn't much of an angle to choose from. You're just going straight down. You couldn't, even if you wanted to, create a meaningful different angle of approach. But you can see how little echo separation there might be, maybe a centimeter here. So you find the angle easy, but controlling the depth is of absolute prime importance going parasternally, and that can be really tricky. So I would say a parasternal approach was the least favorable option.